when you actually peel back the layers, it is surrounded by a surprising amount of, well, mythology.
Oh, for sure.
We are talking about the science, the mechanics, and the biological engineering of contraception.
It's honestly one of the most fascinating intersections of biology and chemistry we have. I really mean that. We treat it so casually now, pop a pill, apply a patch. But what we're actually doing is hacking a fundamental biological drive.
Right.
A drive that has existed for millions of years. We are chemically telling the body to ignore its primary directive.
And that is exactly why I wanted to do this episode. We've been reading through this, incredibly dense and detailed medical
It's
text.
heavy stuff.
It is. Specifically, a chapter on contraception, edited by Barbara G. Wells, from a larger text on gynecologic and obstetric disorders. And my biggest takeaway was that most of us are operating on, version 1.0 knowledge.
Yeah, that's a good way to put it.
We know the pill prevents pregnancy, or condoms block sperm. But the actual mechanisms, the how, it's a black box for most people.
Which is dangerous because when you treat it like a black box, you miss the nuance. We aren't just going to list efficacy rates today.
Right.
We're going to look at the engineering. How do you chemically convince the brain that the ovaries are, on vacation? How do microscopic pore sizes in organic material determine whether you're safe from a virus? And frankly, the risk factors.
Oh, the risk factor.
The fine print in this text is some of the most critical information I've ever seen.
That is the mission. We want to move from, I take this because my doctor gave it to me, to, I understand how this molecule interacts with my pituitary gland. And for me, the thing that kept jumping out from the source material is this massive gap between perfect use and typical use.
The human element.
Exactly. The text lays out these incredible success rates in clinical trials, but then shows the real-world data, and the drop-off is staggering.
It's huge.
It turns out the biology is perfect, but humans are, we're glitchy.
We are the variable that messes up the equation, but you can't understand how to disrupt the system or where the glitches happen unless you understand the system itself.
Right.
You cannot hotwire a car if you don't know how the ignition works.
So let's pop the hood. The engine of fertility. The menstrual cycle. I think if you ask the average person, they'd say it's 28 days, you bleed, you ovulate somewhere in the middle.
Mm-hmm.
But the text breaks this down into a really complex feedback loop. It's not just a clock ticking, it's a conversation, a chemical conversation between the brain and the body.
That is the perfect way to visualize it. It is a constant chemical negotiation. It starts in the brain, specifically the hypothalamus.
Okay, the command center.
Exactly. This is the command center. It pulses out a signal called GnRH. That's gonadotropin-releasing hormone. It's like the general sending a radio signal to the troops.
And the troops in this case are in the pituitary gland.
Right. The pituitary gets that signal, and it releases the two heavy hitters of reproduction. FSH, which is follicle-stimulating hormone, and LH, luteinizing hormone.
Okay.
If you're looking at a fertility chart, these are the lines that spike and dip.
So let's break down their jobs, because this is where all the biohacking comes in later. FSH, follicle-stimulating hormone. And it kind of does exactly what it says on the tin, right?
It really does. It's the recruiter. So in the first phase of the cycle, what's called the follicular phase, FSH levels rise until the ovaries wake up. We need a candidate.
Just one.
Well, it just starts with a group. The ovaries respond by recruiting a whole group of follicles. These are fluid-filled sacs that contain immature eggs. But here's the brutal part of biology. It's a competition.
A race.
A race. And only one gets to be the star.
The dominant follicle.
The chosen one. By about day 5 to 7 of the cycle, one follicle just takes the lead and the others, they die off.
Wow.
And this dominant follicle isn't just sitting there. It becomes an estrogen factory. It starts pumping out estradiol. And this is crucial. Estradiol is the architect. It travels to the uterus and starts building the nursery.
The lining.
It thickens the endometrial lining, creating this lush, blood-rich bed for a potential embryo.
And while it's building the nursery, it's also sending a message back to the brain, right? It's not a one-way street.
Not at all. It's a negative feedback loop. The rising estrogen tells the brain, okay, we have a follicle growing, you can stop shouting, so the brain dials back the FSH.
Okay, that makes sense.
But then we hit a tipping point. When that estrogen hits a critical peak, the brain completely switches strategy. Instead of suppressing hormones, it dumps a massive, and I mean massive, amount of LH luteinizing hormone into the system.
The famous LH surge.
That's the one. That is the trigger. That surge is what physically ruptures the follicle and releases the egg. That's ovulation.
The source material was so specific about the timing here. And I want to highlight this because it really dictates the whole fertile window idea. It says ovulation happens 24 to 36 hours after estradiol peaks and 10 to 16 hours after the LH peak.
Which is an incredibly tight schedule, and here's where people get tripped up. The egg. It's a diva. It only survives for about 24 hours after it's released.
Just one day.
One day. If it isn't fertilized, it just disintegrates. But sperm are the infantry. They can survive in the reproductive tract for up to 5 days just waiting.
So if you have sex on a Tuesday and you don't ovulate until Friday, you can still get pregnant.
Absolutely. The sperm are just camping out.
Wow.
Precisely. That is why the text emphasizes that the most successful conception happens if intercourse occurs 2 days before ovulation. You want the sperm waiting at the door when the egg comes out.
So once the egg is out, we move to phase 2, the luteal phase. What happens to that empty follicle? Does it just go away?
No, it recycles itself. It's amazing, actually. It transforms into a temporary organ called the corpus luteum.
A temporary organ.
Yes. And this is the maintenance crew. It starts pumping out progesterone. If estrogen is the architect that builds the walls, progesterone is the decorator that makes it cozy. It stabilizes the lining and keeps it from shedding.
So it's holding everything in place, just waiting for a signal.
Waiting for a text message from an embryo, basically. That message is a hormone called HCG. If an embryo implants, it releases HCG, which tells the corpus luteum, hey, I'm here, don't clean the room, keep making progesterone.
And if that text message never comes?
The corpus luteum realizes it's been ghosted. After about 10 to 12 days, it just gives up. It disintegrates. Progesterone levels crash. And without that maintenance hormone, the lining destabilizes and sheds. That is menstruation. The period starts, and the whole machine resets to day 1.
It's so intricate. So when we talk about contraception, we're essentially talking about sabotage.
That's the right word.
We're looking at that whole sequence: recruit, build, surge, release, maintain, and we're finding the way to break the chain.
Sabotage is exactly the right word. You can sabotage the signal, which is what hormones do, or you can sabotage the path, which is what barriers do.
Let's start with the path, the physical walls. The source material calls these non-pharmacologic or barrier methods.
Yeah.
And it starts with the most basic one, behavior, the rhythm method.
Or fertility awareness, as it's called. The text notes this has relatively high pregnancy rates, and it's obvious why,
It's
right?
like you're guessing.
You're betting that your body is a perfect clock. But stress, illness, travel, anything can shift that LH surge by a day or two. And if you shift the surge, you shift the window. If you're wrong by just 48 hours, you're in the danger zone.
Okay, so let's talk about the actual physical barriers. Some of these feel a bit historical, like the diaphragm and the cervical cap, but they are still in the text, still in medical use.
They are.
And the text had some very strict rules about these that, frankly, terrified me a little.
They are high-maintenance devices for sure. A diaphragm is a little silicone cup that covers the cervix, but it's not enough on its own. No, it's really just a plate to hold spermicide against the cervix. The rule is you insert it up to 6 hours before, but, and this is the critical safety rule, you must leave it in for at least 6 hours after.
Because the sperm are still swimming around, and you need to keep that blockade up until the spermicide has a chance to kill them.
Correct. But you can't leave it in forever. The text warns very clearly about toxic shock syndrome, or TSS. If you leave a diaphragm in for more than 24 hours, or a cervical cap for more than 48, bacteria can proliferate on the device.
And release toxins.
And release toxins into the blood. It's rare, but it's a life-threatening complication.
And regarding the cervical cap, specifically something called the fem cap, there was a note about parity, meaning whether a woman has given birth or not. Why does that matter for a little plastic cup?
It's all about anatomy. When a woman gives birth vaginally, the shape of her cervix changes. It becomes slightly wider, maybe more irregular. The cervical cap relies on a very tight suction seal. So the text notes that failure rates are significantly higher in women who have given birth because getting that perfect seal is just much, much harder.
Let's move to the most common barrier, condoms. We see them everywhere, but the source material made a distinction about materials that I think is a massive public health blind spot.
It's a huge one.
Latex versus lambskin.
This is critical. Lambskin condoms are actually made from sheep intestine. They're a natural membrane.
Right.
And people like them because they transmit body heat better. They can feel more natural. But here's the biological reality. The pores in a sheep intestine are small enough to block a sperm cell, which is, relatively giant. But viruses are tiny.
So HIV, hepatitis, herpes.
They can walk right through the walls of a lambskin condom.
Wow.
If you use lambskin, you are preventing pregnancy, but you are not protected against viral STDs. If you need disease protection, it has to be latex. Latex is a solid polymer. It's impermeable.
And speaking of latex, there was a chemistry lesson in the text regarding lubricants that I feel like everyone learns the hard way.
It is a chemistry lesson you do not want to fail. Latex is a rubber. Oil degrades rubber. It's that simple.
So no baby oil?
No baby oil, no Vaseline, and this is the one people miss. Even certain vaginal medications like Monistat or Premarin cream, they're oil-based.
What happens?
It essentially melts the latex matrix. The structural integrity just collapses in seconds, and you get breakage. You have to use water-based or silicone-based lubricants.
The text also mentioned the sponge. I remember the Today sponge being a cultural phenomenon in the 90s.
Oh, yeah, the Seinfeld episode.
Exactly.
Yeah.
But biologically, it's just a spermicide delivery system. Right?
It is. It's a polyurethane foam that's saturated with non-oxynol 9.
Yeah.
You wet it, you insert it, and it works for 24 hours. But again, the TSS risk is there if you forget about it.
Right.
And we really need to talk about non-oxynol 9 itself because it's the active ingredient in almost all spermicides.
The text was pretty harsh on spermicides when they're used alone.
It was, for two reasons. One, they fail a lot. But two, think about how they work. Non-oxynol 9 is a detergent. Its job is to destroy the cell membrane of the sperm.
Okay.
That's great for killing sperm, but your vaginal wall is also made of cells. Frequent use of this kind of a harsh chemical can cause microabrasions, tiny cuts in the vaginal lining.
Which sounds painful, but the text highlighted a darker consequence.
A much darker one. Those microcuts provide a direct entry point for viruses. So paradoxically, using spermicides frequently can actually increase your risk of contracting HIV if you're exposed because you've compromised your body's natural physical barrier.
That is a staggering detail. Okay, so barriers are tricky. They require perfect timing, the right fluids, a good memory. Let's move to the revolution. Hormonal contraception.
The software hack.
This is where we stop building walls and start hacking the software.
This is the elegance of pharmacology. The goal here is to hijack that feedback loop we talked about earlier. We use synthetic versions of estrogen and progestin to trick the brain.
Let's break down their roles, because I think people just think the pill is one thing, but it's usually two drugs working together. Let's start with the progestins. The text calls them the heavy lifters.
Think of progestin as the head of security. It has a three-point plan. First, it targets the cervix. It thickens the cervical mucus to an extreme degree.
What does that mean
So
exactly?
we aren't just talking about making it sticky. It turns the mucus into a chaotic, cross-linked mesh that sperm physically cannot swim through. It basically bricks up the door.
So that's defense layer 1.
Layer 2 is the uterus itself. Progestin causes endometrial atrophy. It thins that lining out.
Yeah.
So instead of that plush bed we talked about, the uterus becomes a hardwood floor.
Not very welcoming.
Not at all. Even if an egg somehow gets fertilized, it can't implant. And finally, layer 3, if the dose is high enough, it blocks that LH surge we talked about.
The trigger for ovulation.
Right. No surge, no ovulation. It's a triple lock system.
So if progestin is doing all that work, what is the estrogen for?
Estrogen is the assistant manager. Its main biological job in the pill is to suppress FSH. It tells the pituitary, don't bother recruiting any follicles, we're good. But clinically, its biggest role is actually cycle control.
What's that?
Without estrogen, that thin lining we mentioned tends to shed randomly, which causes a lot of spotting and irregular bleeding. Estrogen stabilizes the lining, so you only bleed when you want to when you take the placebo pills.
Now we have to address the gap.
Yeah.
The text has this table comparing efficacy, and it is the most humbling thing to read. Perfect use versus typical use.
It's the reality check, isn't it? With combined oral contraceptives, or CHCs, if you use them perfectly, same time, every single day, never miss, the failure rate is 0.3%.
Almost zero.
It's virtually zero. But in the real world, the typical use failure rate is 8%.
8%. That means nearly 1 in 10 women on the pill will get pregnant in a given year.
Exactly. And that is entirely down to the user. Forgetting a pill, starting the next pack a day late, having a stomach bug, and vomiting up the pill, the drug works. The delivery system, the human routine, is flawed.
The text also went deep into the generations of the pill. I've heard of monophasic and multiphasic, but third-generation progestins. That sounds like a sci-fi upgrade. Why do we keep reinventing the molecule?
Because the early progestins had baggage. Chemically speaking, they were derived from testosterone.
Oh,
Yeah, so they had androgenic side effects. They could cause acne, unwanted hair growth, weight gain.
which are exactly the things people want to avoid.
Right. So scientists engineered third-generation progestins like desogestrel and drispironone, which is the stuff in Yaz. These are cleaner. They actually help clear up acne and reduce water retention.
But there's always a bite.
There's always a trade-off in biology. It turns out these newer, more cosmetic-friendly progestins carry a slightly higher risk of blood clots than the older acne-causing ones.
So you're choosing between clearer skin and a slightly higher risk of thrombosis. That is a tough conversation to have at the pharmacy counter.
It is. I mean, the absolute risk is still low overall, but it's not zero, and it's a difference.
Let's talk about alternative delivery, because not everyone wants to or can swallow a pill every day. The patch in the ring. The patch Ortho Evra seems convenient. You just stick it on once a week.
It is convenient.
But the text flagged a pharmacokinetic issue here that blew my mind, something called the first pass effect.
This is so crucial for anyone considering the patch. When you swallow a pill, it goes to your stomach, then your intestine, and then straight to the liver before it hits the rest of your body.
And the liver is a filter.
The liver is a powerful filter. It breaks down a huge chunk of that estrogen immediately. That's the first pass effect. The pill is designed knowing the liver will eat half of it.
Okay, so what about the patch?
The patch, you stick it on your skin, and the hormones soak directly into your bloodstream. They completely skip the liver on that first pass.
So you're getting a much bigger dose.
A much bigger overall exposure. Your body is exposed to about 60% more total estrogen than with the pill.
And more estrogen equals.
Higher risk of clotting. It's a significant difference. And the text also notes a weight limit. The patch is less effective in women weighing over 90 kilograms, which is about 198 pounds.
Good to know. And the ring, the new Varing.
It's a flexible ring that sits in the vagina for 3 weeks, releasing hormones both locally and systemically. It avoids that massive estrogen spike you get with the patch. The main rule here is purely mechanical.
What's that?
If it falls out, you have a 3-hour window to put it back in. If it's out for more than 3 hours, the hormone levels in your blood drop below the therapeutic threshold, and you need backup protection for a week.
This brings us to the scary stuff.
The risks.
The text uses a mnemonic that I think is brilliant. ACHES. If you are on hormonal birth control, this should be tattooed on your brain.
It really should. These are the signs that a blood clot might be forming. Because remember, estrogen increases the clotting factors in your blood. It makes the blood slightly stickier.
Okay, so let's break it down. A is for
abdominal pain. This isn't just a tummy ache. We're talking severe, sudden pain. It could be a clot in the vessels of your gut or even gallbladder issues.
What?
C is for chest pain, sharp pain, shortness of breath. That screams pulmonary embolism, which is a clot in the lung, or even a heart attack.
H is for headaches.
But not just any headache.
No.
A sudden, severe, what they call a thunderclap headache. That is the warning sign of a stroke.
E is for eye problems.
Yep. Blurring, flashing lights, loss of vision. A clot can travel to the retinal artery in your eye.
And S.
S is for severe leg pain, usually in the calf, often with redness or warmth. That is the classic deep vein thrombosis, or DVT. And if you ignore that leg pain, that clot can break off and travel straight to your lung.
It really makes you realize these are serious medications.
Yeah.
And because of these risks, there are people who simply cannot take them. The contraindications.
The list is very strict for good reason. The biggest one is smokers over age 35.
Why that specific age?
Because by 35, you've likely had years of smoking damaging your blood vessels. Estrogen makes your blood sticky. If you combine damaged, rough vessels with sticky blood, the risk of heart attack isn't just additive, it's exponential. It is a hard no.
And hypertension or high blood pressure.
Right. If your pipes are already under high pressure and you add a drug that can increase fluid retention and constrict blood vessels, you are asking for a blowout, like a stroke. If your systolic blood pressure is over 160, you should stay away from estrogen.
The one that surprised me was migraines. I know plenty of people with migraines who are on the pill, but the text specifies migraine with aura.
The aura is the key. That's when you see flashing lights or zigzag lines before the pain hits.
What is that?
That aura indicates a neurological event, a temporary constriction of blood vessels in the brain. People who get aura already have a higher baseline risk of ischemic stroke. If you add estrogen to that physiology, the stroke risk becomes unacceptable.
Wow. However, to be fair, it's not all doom and gloom. The text lists a lot of non-contraceptive benefits. In fact, many people take the pill, and have zero need for contraception.
Absolutely. It's a quality of life drug for so many. It regulates the cycle, it treats acne, it dramatically reduces the risk of both ovarian and endometrial cancer.
Really?
Yes, and that protection lasts for years, even after you stop taking it. It treats dysmenorrhea, which is painful cramps, and helps with anemia. For someone with polycystic ovary syndrome, PCOS, it can be a primary treatment.
So if you are that smoker over 35, or you have the migraine with aura, does that mean you have to go back to condoms?
No, I mean, you have to ditch the estrogen, you go progestin-only.
Which changes the game mechanics again. Let's talk about the mini pill.
The mini pill contains only progestin, so it's much safer for those women we just mentioned. But remember how we said the combined pill has some margin for error? The mini pill has almost none. Because it doesn't consistently stop ovulation, it relies almost entirely on that cervical mucus blockade. And that mucus barrier starts to thin out if you are even 3 hours late taking your pill.
3 hours, that's it.
That's it. If you take it at 8 a.m. every day and on Saturday you sleep in and take it at noon, you might have compromised your protection. It is unforgiving.
So for the forgetful among us, we need to remove the daily routine entirely. We need LRRC long-acting reversible contraception.
The set it and forget it options.
Let's start with the shot, Depo-Provera.
It's an injection in the muscle every 12 weeks. Highly effective. But I have to say, out of all the methods we've discussed, this is the one with the roughest side effect profile for many people.
In what way?
It's the only method that is clearly linked to significant weight gain in some users, but the bigger issue is bone health.
The black box warning on bone density.
Exactly. Depo suppresses estrogen so effectively that it mimics a menopausal state when it comes to bone metabolism. Your bones can actually lose mineral density.
For how long?
The text advises not staying on it for more than 2 years, unless you have no other choice, to avoid long-term osteoporosis risk. Also, if you want to get pregnant soon, do not take the shot. It can take a median of 10 months to a year for fertility to return after your last dose.
Then we have the implant, Nexblendol. This feels like the cyberpunk option. A little rod in your arm.
It is a bit sci-fi. It's a radio-pig plastic rod about the size of a matchstick that's inserted under the skin of your upper arm. It just trickles out progestin for 3 years.
And the effectiveness.
It is incredibly effective, over 99%. It's actually more effective than tubal ligation, getting your tubes tight in some studies, because there was 0 user error.
But the bleeding profile.
That's the catch. Because there is no estrogen to stabilize the lining, irregular bleeding is the #1 reason women get it taken out early. It's completely unpredictable. You might not bleed for 6 months. You might spot for 3 weeks straight. You just don't know.
Finally, the IUD, intrauterine device. This sits right inside the uterus itself. We have 2 flavors, copy and hormonal.
The mechanism here is so fascinating. All IUDs work at a baseline level by creating a foreign body reaction. The uterus detects this object and creates a sterile inflammatory response.
How does that do?
It floods the uterine cavity with white blood cells and prostaglandins. This environment is it's toxic to sperm. It's a hostile wasteland for them.
And the copper IUD adds a chemical weapon to that.
It does. Copper ions are essentially kryptonite to sperm. They inhibit their motility. The Paragard IUD has no hormones, it lasts for 10 years, and it works instantly.
So what's the downside?
Because it works by causing inflammation, it often makes periods heavier and cramps more painful.
Versus the hormonal IUDs like Mirena or Skyla.
These release a small amount of levonorgestrel right at the source, so you get the benefits of progestin, the thin lining, the thick mucus, without high systemic levels in your blood.
And the bleeding.
Because they thin the lining so effectively, they actually make periods much, much lighter. A lot of women stop bleeding entirely. They get amenorrhea, which can be a huge benefit.
I have to ask about the infection myth. I feel like everyone knows someone who says IUDs cause pelvic inflammatory disease, or PID.
That is a ghost from the 1970s, specifically from a terribly flawed device called the Dalkin Shield that had a braided string.
So modern ones are different.
Modern IUDs are very safe. The text clarifies that the risk of PID is only elevated for the first 20 days after insertion. And the reason is that the insertion process itself might push natural bacteria from the vagina up into the uterus. After that initial healing window, the risk drops right back to your baseline.
That is a crucial correction. Okay, before we close, we have to look at the oops scenarios, drug interactions. You're taking the pill, you get sick, you take another medication, and suddenly you're pregnant. What disrupts the system?
It's all about the liver enzymes. The liver is where drugs are metabolized. Some drugs are what we call enzyme inducers. They basically rev up the liver's machinery.
So it works too fast.
Exactly. If the liver is working overtime, it chews up the contraceptive hormones too quickly, and their levels in your blood drop.
The big offender in the text was a drug called rifampin.
It's an antibiotic used for tuberculosis and sometimes for meningitis exposure. It nukes the efficacy of the pill. I mean, it just destroys it. If you are on rifampin, you need condoms, full stop.
What about common antibiotics? You have a UKI, you get amoxicillin.
The text says the risk there is pretty minimal, but you hear anecdotes. However, the bigger category to watch out for is anticonvulsants.
Drugs for epilepsy.
Right. Things like phenobarbital, carbamazepine, these are massive enzyme inducers. If you have epilepsy, the pill is often a very bad choice. You're much better off with an IUD or the shot, which either bypass the liver or are robust enough to handle that interference.
And finally, emergency contraception, Plan B.
Yeah.
There is a persistent myth that this is an abortion pill.
We need to be so biologically precise here. It is not. Levonorgestrel, which is Plan B, works primarily by stopping the ovary from releasing an egg. It delays ovulation. It keeps the door locked for a few more days until the sperm die off.
But what if the egg is already out?
Then Plan B does very little. And if fertilization has happened and the egg has implanted in the uterus, it does nothing. It will not detach an established implanted embryo. It is contraception, not abortion.
And timing is everything.
The sooner the better. Within 72 hours is the standard window. After that, the efficacy just plummets. There is a prescription option, a drug called ulipristal, that can buy you up to 5 days, but again, you are racing against that ovulation clock.
This has been a massive download. We've gone from the hypothalamus all the way to the copper ion. When you step back and look at this entire landscape, what is the synthesis? What's the main takeaway?
I think the takeaway is that there is no free lunch in biology. Every single method is a trade-off.
Right.
You want perfect control and predictable cycles. You take the pill, but you accept the daily discipline and that slight clot risk.
Okay.
You want zero effort and super high efficacy. You get an implant or an IUD, but you might have to surrender control over your bleeding pattern. You have complex health issues. Then you have to navigate the contraindications very, very carefully.
So it's about customization. It's realizing that birth control isn't a single thing. It's a menu of different tools to hack your specific biology.
And it requires active participation. You can't just be a passive patient. You need to monitor your blood pressure. You need to check your IUD strings. You need to know if your migraine just changed its patterns. These are powerful tools, not candy.
It really is profound when you think about the evolution of this. For most of human history, fertility was something that just happened to you.
It was the default state.
It was a default state. We tried to block it with physical walls, with barriers, but now we have reached a point where we understand the chemical language of the brain so well that we can just turn the switch off.
We can make fertility optional.
We can treat it like a subscription service. We can pause. With a copper IUD, you can turn it off for a decade. That shift from fertility being destiny to fertility being a choice managed by precise biological engineering, that is one of the biggest changes in the human experience. And I guess the question for you, the listener, is, now that you know how the engine works and how the brakes work, are you driving the car or is the car driving you?
That is the question.
Thanks for diving deep with us.
Always a pleasure.
See you next time.